Welcome everyone to our second webinar in a three-part series on fall risk screening and assessment. We've got people joining us as I speak here. So I'm gonna get started, but at our last webinar, we talked about fall risk screening. The focus of today's webinar is fall risk assessment for older adults. And today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman. I am the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. And in case you weren't aware, Parachute now sponsors the Fall Prevention Communities of Practice Loop and Loop Junior, along with the annual Fall Prevention Month campaign. Before we get started, I just want to begin today's presentation with land acknowledgement. Today, we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and unceded territory of the Indigenous people of Canada, Canada's First Nation, Inuit, and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights and the title of Indigenous peoples of Canada, and declare our respect of Indigenous elders, past, present, and future. I would ask that everyone take a moment to themselves to acknowledge the land where they currently reside. Next, I just want to cover a few housekeeping items. During the webinar, if you have questions about the technology, please type them into the chat box. My colleague Marguerite, who you might have seen already active in the chat box, will be monitoring this. If you have questions for our presenters about the webinar and its content, please submit them through the Q&A box. They will be answered at the end of the webinar. You will only be able to view questions you have asked and not questions posed by other participants. The webinar is being recorded and a YouTube link will be sent to all participants in about a week or so, along with the presentation slides. You can view previous webinar recordings simply by heading over to the webinar page on Loop and clicking on archived webinars. You can also access archived webinars from the services drop-down page on Loop or at our YouTube channel. As a reminder, based on the feedback from our last webinar, we've extended the timing of this webinar by 30 minutes. So the webinar is going to run from 12 p.m. to 1:30 p.m. Eastern. So this should give us plenty of time for discussion and questions at the end of the presentation. If you can't stay for the entire time, no problem at all. You can watch the rest of the webinar via the recording that I'll send out in a few days. So I want to now introduce our presenters. Brian Heineman, professor at the Michener Institute of Education at University Health Network, Denise Beaton, senior policy analyst at the BC Ministry of Health and a member of the BC Injury Research and Prevention Unit, and Dr. Richard Louie, injury prevention specialist at Trauma NB. For a complete bio on our presenters, please take a look at the Loop event calendar. But without further ado, please take it away. Brian, you can now start sharing your screen.
Okay, will do. Okay, thank you, Michelle, and good afternoon, everyone. So I'm going to be giving a brief overview of current clinical practice guidelines that are used to assess fall risk in older adults. But before I go there, I just want to make sure that we're on the same page about the difference between fall risk screening and fall risk assessment, because I know that sometimes those terms tend to be used interchangeably. And the definitions that you see on this slide are helpful distinction that were provided by the Registered Nurses Association of Ontario in their document, Preventing Falls and Reducing Injury from Falls. So basically fall risk screening measures are short tools or checklists that are designed to identify individuals at risk of falling and also they're used to determine if there's a need for a more comprehensive evaluation of the individual's fall risk. Fall risk assessment resources are more detailed and more comprehensive. They're best described as algorithms or protocols that identify the comprehensive range of fall risk factors that can be targeted for intervention. And there are many fall risk assessment resources that take the next step and identify best practice interventions that can be used to prevent injurious falls among people who get screened as being at or assessed as being at high risk for falls. Most of the resources that fall into the category of fall risk assessment take the form of something called clinical practice guidelines, or CPGs for short. And this is a definition that was developed by the Global Task Force on Falls, and they define clinical practice guidelines as evidence-based recommendations, which are often created through expert consensus building processes involving clinicians, other healthcare practitioners, to ensure that the most appropriate course of action is taken to diagnose, manage, and care for older adults at risk of falls. Clinical practice guidelines are used across the continuum of care. There are clinical practice guidelines to assess fall risks for independent older adults dwelling in the community, all the way up to resources, clinical practice guidelines assessing fall risks for older adults in long-term care settings. So what do we know about commonalities and differences across the plethora? And I say plethora because there's at least probably 50 or 60 that I know of offhand, clinical practice guidelines. Well, until recently, there was comparatively little work done to identify commonalities and differences shared by clinical practice guidelines. But over the past year, there have been two major initiatives in this area. One was a scoping review conducted by Williams, Robertson colleagues at the University of Saskatchewan, and they looked at 22 clinical practice guidelines, including 4 Canadian guidelines. And secondly, the Global Task Force on Falls recently published a systematic review of 15 clinical practice guidelines, including 2 Canadian resources. I do have the references for both of those publications at the end of my presentation, and I encourage you to go and download them and check them out if you want to know more. So what do clinical practice guidelines have in common? Well, Williams, Robertson colleagues found that over 86% of the clinical practice guidelines that they reviewed, 19 out of 22, including all 4 of the Canadian CPGs, used 2 main screening criteria for fall risks, that being a prior history of falls and abnormalities in gait and balance. So that's a key similarity that seems to be shared by a number of fall risk assessment clinical practice guidelines. Both of the reviews of CPGs also identified a number of similarities in content domains. They found that most of the clinical practice guidelines include a detailed fall history, a detailed evaluation of gait, balance, or mobility, medication review. Now, there's some differences between the guidelines in how medication use is assessed, but it tends to be included as a content domain area. Also vision, cognitive status, postural hypotension, different environmental assessments for hazards, ranging in scope from household hazards like loose floor mats all the way up to the social determinants of health like education, housing, transportation, income. exercise interventions, as well as multifactorial interventions. As I mentioned, clinical practice guidelines for assessing fall risks often go beyond just screening to include recommendations for interventions to prevent future falls. And they often include interventions regarding exercise as well as other factors. And another similar content domain that was shared by a number of clinical practice guidelines is advice about the active management of osteoporosis and fractures, both of which are risk factors for falls. So those are some of the similarities. What are some of the key differences? Well, there's certain areas that don't get addressed as often in clinical practice guidelines. Some of the less addressed content domains include interventions addressing vision or footwear, physiotherapy referral, and cardiovascular related interventions. Most of the clinical practice guidelines seem to be silent on recommendations regarding hip protectors and wearables, digital technologies. That was a gap that was identified in the systematic review conducted by the Global Task Force on Falls. There are some recommendations that tend to be inconsistent across guidelines. Those include recommendations for managing medication side effects that may contribute to falls. Also, vitamin D supplementation. Some guidelines don't address it at all. Some guidelines do address vitamin D supplementation, but they provide inconsistent advice regarding that particular issue. Now, here's a key difference. There's considerable variance in the scope of clinical practice guidelines for fall risk assessment. They range from basically detailed algorithms or logic models with a few recommendations and some recommended protocols, all the way up to documents that are hundreds of pages long that give comprehensive descriptions of both risk factors and options for intervention. So even though fall risk assessment clinical practice guidelines is a bit of an umbrella term, there's really quite a bit of variance in the breadth and depth of detail between those guidelines. And the last difference is that some clinical practice guidelines embed standard fall risk tests like the TUG test, also the Berg Balance Scale or the Tenetti Performance-Oriented Mobility tests. Some of those tests are embedded directly into fall risk assessment guidelines, whereas other clinical practice guidelines have developed their own in-house measures for assessing fall risks instead of using the popular standardized tests. So that gives you a sense of similarities and differences between fall risk assessment clinical practice guidelines. I just want to end with some key priorities to guide future work in this area. A number of studies have noted that there needs to be more development of optimal screening measures that get incorporated into fall risk assessment. Standardized tests like TUG don't always have the best predictive validity for forecasting fall risks. It might be more effective to use self-report measures, direct observation, some combination of both or other checklists. More work needs to be done to identify the most critical assessment components of clinical practice guidelines. There's a lot of common content domains in the clinical practice guidelines, but are they the right domains? Are the clinical practice guidelines focusing on the right content, or are there missing elements, or could they be pared down? Are there content domains that may not be as necessary? There's some consensus that more research should be done regarding the optimal timing and frequency of screening and assessment for fall risk. Most of the clinical practice guidelines focused on acute and long-term care settings recommend screening for falls upon admission. Others recommend screening for falls following changes in health status, or maybe screening for falls after an older person has moved to a new environment. And I can attest to this through my personal family history. Older people in my family who I know who experienced falls did so after moving to a new apartment or a new facility that they weren't as familiar with. So maybe that might be a good time to screen older adults for fall risks. Just quickly end with some other priorities. The issue of optimal balance between one-size-fits-all clinical practice guidelines and some contextual factors like geography, where people live, cultural values around exercise, climate, how severe a winter might be in any given jurisdiction. I'm raising this because there's been a proliferation of clinical practice guidelines over the past decade. There's more being created as we speak. I don't know if every jurisdiction or organization addressing fall risk needs to develop their own guidelines, but at the same time, we do need to recognize that there may be some factors that warrant some differences in the content of guidelines. Achieving a more optimal balance between what's really essential to cover in clinical practice guidelines and the logistical and practical factors affecting the administration of those guidelines, especially time, resources, staff training, etc., which is closely tied to the next point around focusing on what are the organizational, community, and system level barriers to fall risk screening and assessment, like siloing in the broader healthcare system, to the time that people have in organizations. There was an American survey that was done last year on fall risk screening, and 90% of respondents to that survey said that they were not able or willing to spend more than 5 minutes on screening any one individual for fall risk. So that tells us something about just how detailed in scope some of these clinical practice guidelines can realistically be in a healthcare setting. And my last point is there needs to be greater patient engagement in the development of clinical practice guidelines. That was identified as a major deficit in a recent review by the Global Task Force. They found that there was little, if any, patient involvement and patient consultation in the development of clinical practice guidelines. So that's a deficit that needs to be rectified in order to make sure that these guidelines reflect patient and caregiver needs. So that's it for my presentation. I know that we're holding questions until the end, but maybe if there's time, if people have any maybe immediate questions of clarification regarding the content of my presentation, I'd be happy to answer those now. And here are the references that I referred to, including numbers 3 and 4, which are the recent reviews of clinical practice guidelines that I spoke to in the presentation.
Thank you, Brian. No clarifying questions have come in, so we'll probably jump right into Denise's portion of the presentation. Brian, just a note, I turned off your video just because your connection was lagging a little bit. It helped a bit, but I hope everyone was able to still catch everything that you've shared, and thank you for your portion of the presentation. I'm going to hand it off to Denise now.
All right, thank you, Michelle, and thanks, Brian. Okay, so my name is Denise Beaton. My background is in gerontology, and I'm also, as Michelle mentioned, a senior policy analyst at the BC Ministry of Health, a member of the BC Injury Research and Prevention Unit, and I'm currently a PhD student at the UBC School of Population and Public Health. So this is all just to say, I'll be talking about clinical practice guidelines that I was part of the working group to help develop, but my focus is more so from a population public health view. So at the first presentation in the series, I spoke about the provincial context that led to the development of these Made in BC guidelines for fall prevention. And they came out in September 2021, so they weren't included in the scoping reviews that Brian mentioned. So this might be a bit newer information. I was taking notes during Brian's presentation saying, okay, we got that. Yes, we got that as well. So the guidelines really looking at risk assessment and management for community dwelling older adults, as well as recommendations for screening for fall risk. So really with this presentation, I'll be going over the now what. You have a patient who's been evaluated at fall and injury risk. What are the next steps? So it will be fall history, multifactorial risk assessment. Just as a quick reminder, the focus of this guideline is community-based primary care, but it might be useful to other care contexts as well. When we were specifically developing this guideline, hospital and facility-based care settings were outside the scope. So given that the risk factors associated with falls and fall-related injuries are categorized into 4 dimensions, biological, behavioral, environmental, and socioeconomic, the categories of assessment follow that logic. So fall history, functional review, medical review, and social and environmental review. For patients with multiple health concerns, we do recommend that clinicians consider using rolling assessments over multiple visits, targeting at least one area of concern at each visit. So I'll be going over the components of each of these reviews, as well as the recommended management. And so for fall history, here are the main questions recommended that clinicians ask. And just to help illustrate this, at the last presentation that we did, the first one in this loop series, a participant asked whether someone sliding off the edge of a bed is considered a fall. Now, unfortunately, we didn't have time to address that question. And that's one of the reasons why at this webinar, we're having a longer Q&A period. But I thought it might be interesting to talk about it in terms of a fall history component, because obviously, in order to answer if it's considered a fall, we need more information. So the standard definition of a fall that we use in this guideline and that the World Health Organization also uses is that it's an event in which results in a person coming to rest inadvertently on the ground floor or other lower level. So it's not due to an outside event to which anyone would be susceptible, such as an earthquake. Now, the ICD codes on falls does include a code for a fall from furniture. So it's common enough to warrant special mention in the 10 or so fall-related codes. So by that definition, yes, it was a fall. But was it a fall that would raise concerns about the risk of future falls? Is it of clinical interest? We would need more information. So was the person sleeping and having a bad dream and rolled out of bed onto the floor? That's an event to which anyone could be susceptible. Or maybe they were awake and felt dizzy prior to falling as they were trying to get out of bed, associated symptoms preceding. Does this happen often, or was it a one-time thing? Have they had falls in different circumstances, awake and walking around the house? Did the fall from the bed result in injuries or a fear of falling? Did the person implement any post-fall intervention to prevent it from happening again? So perhaps they put a glow-in-the-dark sticker on their lamp switch so they could easily locate it in the middle of the night and get out of bed with better perception. So as you can see, we have to ask a lot of questions to understand the fall history. So moving on to functional review component, we cover all of these things here and then into management. I'm going to kind of blaze through this so that we have time for the final presentation and questions and answers, but yeah, all of this is online as well. So just jumping right into discussion management. So we do have an associated document in the guideline around exercise prescription and local programs in BC. And I think that is an argument for perhaps not individual jurisdictions creating their own clinical practice guidelines, but certainly translating clinical practice guidelines into the local context, because we are able to, specifically for referrals, talk about the specific programs that are available in BC that focus on balance and strength, that suits individual patient levels, and includes appropriate increases in intensity. We recommend that the clinician considers fall history, frailty, functional abilities, current exercise level, as well as reviewing medical comorbidities, including cognitive status and motivation for exercise prior to recommending any specific program. Also looking at barriers such as transportation and what options might be preferable. We do have a number of exercise videos on Finding Balance BC, for example. And then for older adults with issues with pain or balance or gait, we recommend referral to allied health. And then in terms of support, the guideline does discuss alert devices and home technology. So it talks about them and about using them, but of course, keeping in mind that not every client or patient would have means to take advantage of things such as Philips Lifeline, SafeTrack, GPS Canada, Safeguard Medical Alert, TELUS Living Well Companion, or even the Apple Watch Series 4 or 5, which has a falls sensor to detect falls and will automatically call for help if set up and linked to a phone. But there are features that somebody might have this device and not even know that they could be using it to increase their safety in regards to falls. So we also discussed that if the patient has recurrent falls, it's worthwhile to consider injury prevention through hip protectors and helmets, or even head protection. And then, so going on to continuing the suggested management in this category. So for limitations in activities of daily living, such as mobility, nutrition, lifts and transfers, bathing, dressing, grooming, and toileting, we also recommend considering referral for occupational therapy, home care support, to social work. And then, once again, because it's a local guideline, we have links for referral for local health authorities through home and community care. And then depending, this could be an appropriate time to review safe transportation options and driving skills. So on to the components of a medical review. For comorbidities and risk factors, guideline recommends paying particular attention to medical conditions associated with gait and balance disorders, and it has a full list of them in its first appendix, including cardiovascular diseases, neurological disorders, sensory abnormalities such as hearing impairment, musculoskeletal disorders such as arthritis, gout, as well as infections, metabolic diseases, mental health and substance use, and sleep disorders. And then when there is a comorbidity that has an associated BC guideline, they're linked to it. And then, of course, also important is medication review. So for suggested management, it really is to optimize the treatment of comorbidities that increase the risk of falling, or comorbidities such as osteoporosis that increases the risk of fracture from a fall. So there's a separate appendix in the guideline on medication review, and the suggested management is to consider withdrawing or minimizing the use of psychoactive medications, cardiovascular medications, sedatives, or medications with anticholinergic side effects. Because oftentimes, somebody, if they're managing a chronic condition for perhaps even decades, they may continue taking the same dose that they had when they were younger, not realizing that as they get older, that dose may no longer be appropriate. And so we really do recommend a medication review. And this could be something that the physician does themselves, or it's also something that a pharmacist can do. And I will mention, during Fall Prevention Month in November, pharmacists are one of our key partners in disseminating public health information. So truly a strong allied health partner that has a key role to play in fall prevention. And so continuing on with medical review. So for nutrition and hydration, it's recommended to assess volume intake and loss. So for example, diarrhea, vomiting, fluid restriction, diet and appetite, any weight loss or sudden gain, dentition, so the condition of the teeth, and swallowing. And then for continence, rushing to the bathroom in the middle of the night can be a significant factor in the cause of falls. And it's recommended to assess urinary and bowel continence and causes, and also to assess vitamin D intake. So for the management of nutrition, a supplement can be considered, and the patient can be directed to a dietitian either through the HealthLink BC website, which is the Ministry of Health website, or by calling 811, which is the Ministry of Health number that has a number of allied healthcare professionals who can give advice. And they can also be referred to dietitian services at a local health unit or hospital outpatient services. And then depending on their needs, referral might be recommended to a speech-language pathologist, a dentist, or a denturist for dentures. And then for continence, since it can be affected by medications, keep that in mind when doing the medication review or, mentioned to the pharmacist. And then a bowel protocol is recommended. So that's essentially a care plan to address specific issues. And in certain jurisdictions in BC, there are nurse continence advisors. So depending on the jurisdiction, that's also an option for referral. And then for vitamin D intake, so vitamin D supplementation is recommended in Northern Hemispheres, but it's important to note that it's not effective for fall and fracture prevention. However, it can promote muscle strength. So for that reason, we have included it in the guidelines. And then we also link for specific recommendations on vitamin D and patient risk of osteoporosis. We recommend that the clinician refer to vitamin D testing and the BC osteoporosis guidelines. And finally, the components of a social and environmental review. So of particular focus is substance use, including alcohol, cannabis use, and illicit drug use, as well as environmental home hazards. So asking about potential home hazards such as stairs, lack of handrails or grab bars, poor lighting, slippery or uneven surfaces such as throw rugs, a tub floor. So, those sunken floors that, they had in Mad Men, and some places might still have, obstacles and tripping hazards. And we also recommend considering seasonal hazards outside the home, such as snow and ice. And finally asking, about whether or not they live alone or, their experience of social isolation. So for management, regarding substance use, there are recommendations to refer to the BC Guideline on Problem Drinking and the Canadian Low Risk Drinking Guidelines. To my knowledge, similar harm reduction guidelines don't currently exist in BC or Canada regarding cannabis or certainly illicit drug use. And in fact, much of the research that we drew on to translate this guideline only recommended asking about alcohol use. So we included cannabis and illicit drugs to recognize that they may be used by older adults. And, it's an option to have that conversation about how that use impacts their health and safety and can be managed. For environmental home hazards, we recommend referral to an occupational therapist for home assessment and environmental modification, and to consider directing the patient to access home care services through betterathome.ca. The guideline also includes further information on environmental handouts and two-patient handouts, so checklists of preventing falls at home and tips to stay fall-free in winter. And just thinking about Brian's earlier presentation, when we were creating this guideline, we did have the patient-facing resources. There's about 6 to 8 patient-facing resources reviewed by older adults in a chronic disease management program. 52 older adults reviewed them and provided feedback, and we took that into consideration. But I will say that this was unique for BC guidelines. Typically, they didn't solicit the opinions of patients, although they are changing that practice now. And something that we're doing moving forward in developing fall public health information is also reaching out to family caregivers as well. So there are those patient handouts. And then for those living alone or experiencing social isolation, we recommend community referrals or social prescribing, similar to the exercise prescription, using services to promote health and reduce social isolation. And so I've talked about a lot very quickly. If you'd like to review it in detail, you can click there. Or, if that link's not working for some reason, just search BC guidelines, and this fall prevention guideline, given that it's fairly new, will still be on the first page. And then just, in an attempt to make this presentation more interactive, I've put together a couple quiz questions. So the first one is, what is the most beneficial intervention to reduce risk of falls? And the options are A, exercise that increases strength and balance, B, vision assessment, C, medication review, or D, home hazards assessment and modification. So you can just answer it there on the poll. And I'll let Michelle let me know when we've got the answers in.
Yeah, I'm going to give a couple more seconds. We're at 67% of participants, 70%. So I'll give a couple more seconds, and then I'll close the poll and we can talk about the results.
Sure.
I'm going to go with 75%. So, and there we go.
All right. Okay. Awesome. All right. So this is a bit of a tricky question, and I'm not going to necessarily say that any of these answers are wrong, but I will say that the single most effective fall prevention intervention is A, participation in the safe exercise program designed to improve strength and balance. I say it's tricky because this is the answer at the broad population level. At the individual level, perhaps the biggest issue is, something that could be considered a quick win, like somebody is taking a medication that's making them dizzy, and this can be addressed through deep prescribing. But generally, the most effective thing is exercise, and all other fall prevention interventions in this list are effective when they're completed in combination. So on to the next question. Yes, there we go. Oh.
Sorry, prematurely launched.
That's okay. I can just jump into it from here. So why is clinical fall risk assessment recommended for those at high risk over self-assessment only? So A, it is more accurate. B, it is more effective at influencing health behavior change. C, it's more feasible. Or D, A and B.
Give it a couple more seconds. We're almost at my 75% threshold.
Sure.
Oh, we seem to, one more percent. I'm very attached to this threshold. All right, we may not make it. Oh, wait, there we go. Thank you, whoever that was.
All right, yes. A and B. Okay, people here have participated in standardized testing. They know if there's a multiple choice, it's usually that one. But yeah, exactly. So the answer is D, both A and B. So obviously, a clinical all risk assessment is much more thorough, as just shown through, Brian and myself walking through all the different categories. And it's also, because it's more thorough, more accurate than a self-assessment. And for that reason, it's recommended for those at high risk of falls. It's also recommended that the clinician follow up with their patient between 30 to 90 days, and the clinical assessment results in referrals and a detailed care plan. And Furthermore, coming to the behavior change, research has shown that older adults are more likely to adopt fall prevention behavior if recommended by a clinician. This is out of respect for the expertise of the doctor or nurse practitioner, but also out of recognition that it must be something that's important if it's the subject of a clinical visit, right? And also perhaps the new knowledge that falls are not a normal part of aging and they are in fact preventable. So I'll just click through to the last question here. Here we go. What is the most frequent way older adults who have experienced a fall report managing their risk of future falls? So is it adopting a strength and balance exercise routine? Is it being more careful? Is it reporting a fall to their doctor? Or is it seeking fall prevention information online?
Couple more seconds. So if you haven't put your answer in, feel free before I close the poll. There we go.
Okay, yes, absolutely. That's the right answer. Being more careful. At our last presentation, I mentioned that only half of older adults who have experienced a fall tell their doctors about it. A participant asked why that was, and unfortunately, we didn't have enough time to answer then, but there are a number of different reasons. Firstly, the lack of knowledge that falls are preventable, that it would be of interest to the doctor, the stigma around falls, fears of losing independence, that if the doctor or the family found out, they would want the person to move to a care home, and misunderstanding the cause of falls, thinking that it's due to something external like a tripping hazard, so they need to be more careful, when in reality, it's more so due to not having the leg strength necessarily to, when you have a trip, put the next foot out and stop yourself from falling. So that's really the difference from, say a younger person with more muscle strength, tripping over a pile of magazines on the stairs and then putting the next foot out and stopping the fall and just having it be a trip, right? And so that's why strength and balance exercise is the most effective, because anybody can increase their strength and balance, and all of the other interventions are useful when done together. So there's that little check mark. And then I'd like to quickly acknowledge everybody who was part of the Guideline and Protocol Advisory Committee proposal group, and then the Development Working Group. And obviously, thank everybody for tuning in. Here's my contact information. As many of you know, this is the second in a series of 3 presentations. At our final presentation, I'll discuss implementation and evaluation, because that's the biggest overarching so what. Now we have a guideline, but really it's only as good as its implementation. So thanks very much, and I'll hand it over to Dr. Richard Louis.
All right, well, thank you so very much. Today, I'm going to be talking mainly about efforts here in New Brunswick to enhance fall risk assessment efforts, providing additional support to primary care providers and other healthcare providers in order to ensure that fall risk assessments are done for those who need them. So the last presentation, obviously, we talked about fall risk screening, but now proceeding with the next step being conducting a multifactorial fall risk assessment. We all know from previous presentations that it's really important process to help identify the most appropriate interventions that should be implemented for that specific patient. However, primary care providers aren't left by themselves. We definitely encourage a collaborative approach to fall prevention, and mainly multifactorial fall risk assessments with an interdisciplinary team. Now, the first step from screening, we encourage the use of the staying independent checklist with older adults in order to do the screening. However, some primary care providers may decide to use that same checklist in order to have that ongoing conversation around their personal risks for fall. So if we look at the checklist, list of 12 questions, you can see questions like, am I worried about falling? I often have to rush to the toilet. I have lost some feelings in my feet. Those things should really instigate or start that conversation with, help start that conversation with their primary provider in order to help reveal things like assisted device use, foot problems, poor balance, medication side effects, fear of falling, sleeping issues, confidence issues, depression. We can glean a lot of information just by going through the staying independent checklist a second time with the older patient in order to discover those issues. However, just like we encourage healthcare providers to use the algorithm, the reason why is because it categorizes the multifactorial fall risk assessment in 4 categories. The first one being the focused history, where we typically look at the history of fall. And for each one, I'm not going to go into too much detail since we already brought it up during the previous presentation, but just to say, the intent here is to be sure that we're not leaving gaps in the multifactorial fall risk assessment. So in order to be comprehensive, these elements should be taken into account during the focused history. So history of fall, relevant risk factors and comorbidities, completing a medication review, a nutrition and hydration, making an assessment about how they eat and how much they drink, their hydration level. Comments in rushing to the bathroom, just like we mentioned earlier. And lastly, bone health and vitamin D intake. So here, asking those questions and trying to reveal if there's any issues at each one of those elements. Beyond that, we can continue with a functional assessment. Here, looking at mainly the physical activity. How much physical activity do you do? What's their endurance level? What do they do with regards to their activities of daily living? Do they have any difficulties doing those type of tasks? Access and use of adaptive equipment. So do they actually have a walker if needed? Do they use them? So that's that second question that is just as important. Last but not least, perception of functional ability. And this is so important, whether we're referring to an older adult who's overconfident, who might misjudge their ability to complete certain tasks that way, or to deal with fear of falling, where they might be underconfident with their ability to complete certain tasks, where in turn might curtail their ability to be fully engaged in the type of daily activities that they like to do. So to ask further questions around those lines. Beyond that, social and environmental assessment. So like we mentioned earlier, identifying hazards in and around the home, but also looking at community hazards, since we all know that older adults are active members in the community. They might be going to regular activities, whether it's bingo or pickleball, really what type of interaction that they have with the community in order to get to those activities. Obviously, to ask about loneliness and social isolation as a factor that might lead to increased risk of fall, and obviously depression. And last but not least, to ask about alcohol or other substance use, since those could be used as a coping mechanism or just as a way to enhance their social engagement. So it could be used as a crutch in order to counter senses of loneliness, or as the opposite, as a way to enhance the party atmosphere during social gatherings. So to be cognizant of improper or problematic alcohol or substance use. Last but not least, obviously, to complete with a physical examination where you might assess for visual acuity, orthostatic hypotension, mobility assessments. So here we're talking about going beyond the type up and go. Here we might consider more extensive tests like the Tenetti performance-oriented mobility assessment or a Berg balance test. So really to use those type of more extensive assessment that could be done with the older adult. And obviously to think about, like I mentioned earlier, a collaborative approach in order to reach out for support from a physiotherapist or occupational therapist as needed. Foot and footwear assessments and other system examinations. So here, whether it's a cognitive assessment or other type of assessments as needed. Obviously, the most important part here is for primary care providers to use their clinical judgment in order to really focus on those that lead the specific patient to their increased risk of fall. So I went pretty quickly through the different elements, the 4 categories for a fall risk assessment. However, in New Brunswick, like I mentioned earlier, there's an effort to provide even more support for primary care providers and other healthcare professionals with regards to available resources and programs. Here, I'm just going to talk about a few, and namely with regards to assessing fear of falling. Like I mentioned earlier, there's validated tools that are readily available. This is one tool that we are making available for primary care providers across New Brunswick and in other provinces too, upon request. Here, like you can see, is a series of 16 questions where the patient would answer them with the primary care provider in order to really get a better sense about which areas are more elicit more concern. So with that tool, we can get a better sense of which areas provide more concern around fear of falling. Beyond that, other tools where you might, primary care providers might need additional support. And here is a electronic consultation program that's readily available for family physicians specifically. So here, it really assessed with electronic communication between family physicians and a specialist. So when we're talking about making those type of consultations, those are specifically for non-urgent requests for advice. And as you can imagine, there's the ability to obtain support for assessment of risk of fall or other clinical support from specialties like geriatric medicine, neurology, chronic pain management. So this is a really useful tool that we encourage family physicians to use in order to support them in completing a multifactorial fall risk assessment. Beyond that, there's the medication review component, where pharmacy services are able to focus on the appropriate utilization of medication to improve patient outcome through the New Brunswick PharmaCheck program. With this program, it provides a review of 1 per year for eligible older adults who take 3 or more medications for chronic conditions. So if an older adult is eligible, it is recommended to refer them to a pharmacist through the New Brunswick PharmaCheck program in order to ensure that medication review. And really, it's delivered through a 30-minute face-to-face session at a local pharmacy. But our involvement through Trauma NB was to further amplify or to promote the availability of this service, and more specifically during Fall Prevention Month, where we were lucky enough to be able to partner with the New Brunswick Pharmacists Association in order to encourage pharmacists to talk about the reality that falls are not a normal part of aging, and that medications can contribute to fall risk, and to encourage them to make an appointment for that medication review, and also to continue that conversation about prevention of falls with their primary care provider in order to ensure a fall risk screen and then a fall risk assessment as needed. So again, to encourage that collaborative approach to multifactorial fall risk screening and assessment. Now, we talked about being able to get consults or support electronically. Here in New Brunswick, we also have access to a wonderful program called the New Brunswick Extramural Program. Now, this program provides comprehensive home and community-based healthcare throughout the province. And really, their ability, number one, to be known as a known entity that provides high quality care, but also the ability to request referral for fall risk assessments, multifactorial fall risk assessment in certain aspects, like the home safety, in identifying home safety concerns that primary care providers wouldn't be able to do themselves. So having that level of support through the New Brunswick Extramural Program is something of a great asset for primary care providers. Beyond that, the service is delivered by an interdisciplinary team. So just like what we advocate for the collaborative approach, the extramural program already has that embedded in the way that they deliver services. So as you can see, they have healthcare professionals such as registered nurses, registered dietitians, physiotherapists, occupational therapists, and others. So really, especially for those older adults who have difficulty going out in the community in order to have access to specialty services or those type of services, the extramural program is there to provide that level of support. Now, we talked about available resources, and I didn't go through the full list of those resources, but there's ongoing effort to develop either new resources, new programs, new ways to provide even additional support so that we can further enhance fall risk screening and assessment so that the proper interventions are in turn provided to older adults who need them. So one thing that we're currently working on is updating our Finding Balance New Brunswick website, where it did great. We loved our ability to be able to highlight available resources for older adults, healthcare professionals, elders too. But also what we really wanted to do is to make it a very easy way for family members, caregivers, or others who might be interested in fall prevention to have access to simple resources in order to reduce fall risk. So this was a great website that I created nights and weekends. So now it's time to hand it over to the web developers who can take it that extra step to make it even more readily navigatable and easier to be used with mobile devices, for example. So this is one example of how we're continuing our work in order to provide additional support. Another one is to go beyond the algorithm that we've created, and this time to look at the creation of clinical practice guidelines for primary care providers here in New Brunswick. What we're currently doing is looking at BC's guidelines, protocols that were developed by BC Guidelines and Protocols Advisory Committee, and really trying to harmonize the look and feel of our clinical practice guidelines so that we limit the variability across Canada, so that the intent, and this is me extrapolating, but hopefully the intent is to get to a point in the future where across Canada, our clinical practice guidelines will look similar with regards to the steps that would be needed in order to complete the fall risk screening assessment and the management of for community-based older adults. Beyond that, just want to mention that this really provides that extra level of useful guide to facilitate individual fall risk assessments, but also highlights available tools, programs, and services for primary care providers in New Brunswick. Beyond that, also want to mention a new and exciting possibility for 2022 here in New Brunswick is the possibility of implementing fall prevention clinics, learning from the fall prevention clinic model that's been implemented in BC in order to explore through a pilot project here in New Brunswick. Now, our method to complete a multifactorial fall risk assessment rests on a tool called the Fall Risk for Older People in Community, or the FROPCOM for those who are in the know. So really, it's a modified version of the FROPCOM in order to create 5 separate stations where we're going to be assessing all the different elements that we've talked about earlier. Now, obviously, the end goal is to provide support for the eventual implementation of a network of fall prevention clinics. So as you can imagine, yes, having a pilot project with one site being the focus right now is great, but eventually we know that we need to expand across New Brunswick and eventually across Atlantic Canada. So if not across Canada. So really, there's much more to be done, much more collaboration, much more working together in order to get to a point where we feel comfortable that primary care providers are provided with maximum level of support in order to ensure that fall risk screening and assessments are done for all older adults across Canada. And here, before closing up, just want to ask a quick question to encourage self-reflection for those attending the presentation today. And here it is. Do you know if there's any effort in your province or territory to develop new resources or implement new programs to support a collaborative approach for multifactorial fall risk assessments? So what type of support is being provided in your province or territory in order to make it easier to facilitate that process? As we know, much more needs to be done. Working together is a great way to ensure some progress. And for this, I just want to thank BC and Denise Beaton for supporting our efforts that we've been undertaking here in New Brunswick in order to get to a point where we feel comfortable that we're providing the best services for New Brunswickers here in this province. So with that, I'm just going to close it with my picture and my web address and my address. So please feel free to reach out to me if ever you have any questions, and it would be my pleasure to answer any question you might have. And with that, I'm going to pass it back to Michelle.
Thank you, Richard. I'm going to share my screen now. So this has all of our presenters' contact information there. I know there were a couple of questions throughout the presentation just about slides and references and things. And so the slides will be, I'll reiterate, the slides will be emailed out a few days after this presentation concludes. And now we'll move into our question period. Before we do, I'll quickly just say thank you so much, Brian, Denise, and Richard, for another excellent webinar in this series. We did have a few participants submit some questions in the chat box and the Q&A box. So we're going to address these momentarily. If you put your question in the chat box, if you could put it in the Q&A box, that would be much appreciated. And in the meantime, I'll wrap things up with a couple of housekeeping items before we move into our discussion. So if you have any last minute questions, please feel free to drop them into the Q&A. When the webinar has ended, you are going to be redirected to Zoom, and it's going to invite you to participate in a short evaluation survey. So if you click the blue continue button on your browser, you'll be redirected to the survey. And if you could fill that out, it would be very much appreciated. It shapes future webinars, particularly for this webinar. We've got one last webinar in the series, and we love to hear your comments and your suggestions for particular things that we should cover in loop webinars in general, but also please use the last question of the survey where it asks for additional comments. If you have any suggestions for the final and third webinar in the series, if you have any specific things that you want to see covered, put it there. Our presenters are reviewing that, and as you can see from this presentation, they take it into consideration, and they absolutely cover it in the next presentation. So if you have any things that you'd want to talk a little bit more about, please put it there. Speaking of which, the final webinar in the series will be on April 26th. So mark your calendars, and the registration information will be available shortly, but just wanted to plant the seed there. So with that, we can move on to questions, and I'll open these up. I see that a few more have come in. I think the first one, it's thank you, Rhonda. She was clarifying from the first part of the webinar when we talked about osteoporosis before. Denise had gotten to that osteoporosis is not generally considered a risk for falls, but a risk for injury due to falls. So thank you, Rhonda, for that clarification. That's always helpful to have our participants participate like this. So I'll move on to the next one. Our next attendee asks, I am curious about fall circumstances and whether or not falls on stairs are identified. In the same vein, do assessors consider the built environment? For example, is there a handrail or good lighting?
Yeah, so I can take that. I'm assuming that is related to when I was talking about fall history and using the example of somebody asking whether a fall from the bed was considered a fall, and I mentioned it is part of the ICD codes. So I can say that there are ICD codes for falling from steps or stairs, so that does exist. However, whether or not any additional information is included by the person who's taking the fall history, and ICD codes are really used for falls that result in hospitalization, so through the discharge abstract data, or that result in death, so through the mortality data. So from a public health perspective, the majority of what we see, unfortunately, for these ICD codes is unspecified fall, which is the last one. And I was chatting with a geriatrician because we included the codes on the BC guidelines, and he said, "Oh, well, it's just paperwork. I just put them all as unspecified fall." And I said, "No, we in public health, we use these codes for surveillance to actually develop resources and programming." And he had no idea. For him, it was sort of a make work project, something that you had to do before you could do what really mattered, which was assessing patients. So I think in public health, we need to do a better job at communicating why these codes are taken. And perhaps I misread the question and you were asking about assessment in terms of what a PT or OT would do. But
Yeah, I can speak to that question too. Just to mention that here in New Brunswick, we also track DAD data, which does provide that breakdown on the medicanism of fall, whether it was on icy surfaces, same level, from a height, specified height, or from stairs, or even from the toilet, or other furniture. So really, we do have that breakdown. But just like Denise mentioned, unfortunately, we're identifying a concerning trend here in New Brunswick where healthcare professionals are putting down unspecified falls at an increasing rate, unfortunately, where back in 2006, we were seeing about 16% of all falls being labeled as unspecified. Nowadays, around 2018, we've identified closer to 18 to 20% of falls being labeled like that. So like Denise mentioned, there's much more to be done with regards to raising awareness about the importance of proper labeling so that we can in turn provide the targeted interventions within the community in order to really affect change.
Great, thank you, Richard and Denise. Alrighty, so the next question was, do you know anything about the Steady Feet program that was developed by the Falls Prevention Team at Vancouver Coastal Health? Denise, you might be best equipped to answer this one.
Sure, yeah. So I am aware of the program, and my understanding is that it used to be offered through community centers, but it has since been defunded by Vancouver Coastal Health. So I believe it's no longer being offered. And that is, one of the things that the Ministry of Health is looking at, right? Because in order to, the biggest recommendation in the clinical practice guideline is exercise that increases strength and balance, and specifically exercise programs that are designed to reduce the risk of falls. And Steady Feet was one of those programs. There are other programs in BC, but they are generally offered in pockets. So for example, OsteoFed is another great local program, but it's not offered across the province. So it really is an area where I'm petitioning the ministry and many of my colleagues in public health to offer a provincial strength and balance program. And this is going to be something that I'll discuss more in the next webinar around implementation and evaluation. So a little note of what's to come, but unfortunately, my understanding is that Steady Feet is no longer offered.
Thanks, Denise. Alrighty, so moving on to the next question I've got in the queue is, they ask, I'm curious about the New Brunswick Fall Prevention Clinic. It looks like it is mainly assessment. I see that exercises may be recommended, but are they actually practiced?
Yes, very good question. So yes, the fall prevention clinic model is mainly centered around fall risk assessment. However, the last station really focuses on referral to exercise-based fall prevention programs that would in turn work on providing that exercise component, but also the educational component to participants, so that they in turn have a better sense of what they can do in order to further reduce their risk for falls. So programs like Zoomers on the Go, which is a 12-week program where each week there's a different module around fall prevention, whether it's healthy sleep, proper hydration, nutrition, home safety and community safety. There's one for each week where we encourage older adults at higher risk to participate in that program. However, we also want to encourage that link with primary care. So those who go through the fall prevention clinic would be in turn linked with their primary care provider so that they can in turn be fully aware about the interventions that would be recommended to that specific patient so that they can follow up as needed. So really, it's a way to provide that support for primary care provider with regards to screening and assessment, and to initiate a few interventions, namely the exercise piece, while we know that there might be a little bit of wait before they have their appointment with their primary care provider.
Great, thank you, Richard. The next question, and our presenters may not have knowledge of this, but I'll put it out to the group. But I am curious if any healthcare professionals are using mHealth app-based devices to conduct a fall risk assessment. So if you guys know of any, or potentially maybe someone online knows, and they can share in the chat.
Yeah, so I know that BC Guidelines has an app, and clinicians usually access the guidelines through the app, which makes it much easier to go between different guidelines. Specifically, for example, if it gets to the point where it's talking about managing a comorbidity, and then they can just click through to that. I don't believe that it has the functionality of, actually developing a care plan within that, or linking in any meaningful way to all the other processes in the clinic. So that's something that could be looked at. And then in terms of other health app-based devices that are used by older adults themselves, it's something that we considered, and there's a lot of exciting research coming out about how, for example, Brian mentioned that the TUG and the Bird Balance Scale, these tools are limited in their predictive validity of future falls. But there is some interesting research coming out about how when you pair them with, wearable tech that can get even more detailed information, it has more predictive validity. But sometimes I think of, the triangle: fast, cheap, good. And that's usually, we're talking about like services, like food. It can be fast and cheap, like McDonald's, but it's not necessarily good, and so on and so forth. So I think in terms of assessment, there's probably a similar triangle that we can think of where it's feasible, accurate, and maybe the last one stays as cheap, or that's part of feasible, right? So what we currently have really is the very baseline of what people can be doing, which is these assessments. But I think in the future, we will see more use of mobile health apps that the clinicians use, and then also pairing fall risk assessments with wearable tech as this becomes more normative. And, certainly with the pandemic, virtual care and virtual healthcare has taken off more and more. But at the same time, I do think there are certain assessments that can only be done the old-fashioned way.
Thanks, Denise. I just noticed a kind of a related question in the chat box, but they asked if you could specify this app that you referred to that the BC government has.
Yeah, so I believe it's only for clinicians, but essentially it's all of the BC guidelines. So if you go to the website, it lists all of the BC guidelines, the clinical practice guidelines, but clinicians are able to actually just have an app on their cell phone for the guidelines and to click through the guidelines. So really it's mostly just the website, but for mobile use, so that it's formatted better for a cell phone. So it's not too exciting, but it does make it a bit easier to jump between guidelines and just check your phone.
Yeah, absolutely. Great. Thank you for clarifying that. I'll go back up to the top of the queue. The next question asks, can you share any evidence how effective hip protectors really are? That might be a big question, but we'll see what we can answer in the time that we have.
I can speak to that. Could you enable my video, Michelle, so I can engage with people? It looks like I can't start it again. Thank you.
Yep. All right. Perfect.
Okay. Yeah. There was a Cochrane review of the efficacy of hip protectors. It was published, I think, back in 2014. It was a Cochrane review of 14 different studies, and they concluded that hip protectors were promising in preventing fall-related injuries among older people living in supervised facilities. As a caveat, they did note a number of factors like compliance, adaptability, custom fitting hip protectors, etc., hygiene issues that could limit their effectiveness in practice, but they were identified as, I guess you could say, maybe a promising practice, and there was some evidence based on the Cochrane collaboration review of their efficacy in preventing or I should say mitigating the impact of fall-related injuries.
Awesome. Thank you, Brian. All righty. The next question is actually more of a comment, but someone sharing that in Ontario, many regions have their own falls prevention program through public health, Victorian Order of Nurses, hospitals, etc. Geriatric teams are also available. MedRisk is helpful for multidisciplinary consults. The Center for Effective Practice, or CEP, a federal not-for-profit that focuses on knowledge translation in primary care, has a fall prevention tool and an academic detailing discussions with family physicians funded by the Ministry of Health to enable fall preventions into practice. And they share a link to that program. And the eHealth Center of Excellence and CEP have also recently published a free TELUS PSS falls prevention EMR tool and a fall patient checklist that has been developed through CEP, similar to the New Brunswick one. So thank you so much for sharing all that information. I saw it also ended up in the chat. So if you prefer to, if you're more of a reading learner rather than an auditory learner, or please feel free to review that information in the chat as well. And thank you again to the participant who shared that. The next question, with all the research into clinical-based practice that was done by our speakers, was there an assessment tool that stood out as being the best to use, or is it best to use a universal fall approach which sees everyone at risk?
So I can answer this, and then, if people want to join in. I think this is really more so about screening, which we discussed in our first webinar in this series. And so New Brunswick and BC uses a similar approach. It's the 3-question approach, where the clinician asks, have you experienced a fall in the last 6 months or year? Do you experience any issues walking, etc.? And then also using the staying independent checklist, which is a 12-question checklist, which the older adult can do themselves at home and then bring in or in the waiting room of the clinic. And that's a way to identify falls risk, like those at high risk of falls, which is who we recommend would have the multifactorial fall risk assessment, because obviously these assessments are lengthy. So we really only recommend that it be done for those who are at high risk of falls. And sorry, questions are moving. Yeah, so I think in terms of screening, using those tools, and then for assessment, it really has to be individualized about somebody's specific risk factors. And we do stratify people in screening for high risk and no risk of falls, but of course, the universal approach, everybody is at risk of falls, including you and I. We only really said no risk to show that it is not a high enough risk to influence their care plan for the next year. And then we recommend that people are asked about their falls risk annually. So yeah, if you haven't seen the screening webinar, it is recorded, so please do check it out, or email us any questions. I'm not sure if anyone wants to add.
Yeah, the only thing I would add, there's no specific tool. It's mainly the process, right? If you look at the algorithm that we use here in New Brunswick, it really outlines the content of what should be included in the multifactorial fall risk assessment. So those 4 categories: the focused history, the functional assessment, the social and environmental assessment, and physical examination. So as long as primary care providers are respecting the fact that there's those 4 elements that should be looked into, and to use their own clinical judgment and to really knowing where they need to put the focus on, because as you can imagine, there's no single test that could be able to do everything, or that would be more relevant than any other. Obviously, if I had to pick one, if I had to pick one, this is where really the history of falls, right? Knowing fully well that we know that a person who had a previous history of fall is likely going to be falling again is something that we really need to focus on. Beyond that, like I mentioned earlier, is to be able to be comprehensive in your multifactorial risk assessment. And one thing that we advocate is for primary care providers, if they can't complete the full multifactorial fall risk assessment during their single appointment, would be to create rolling appointment where they could complete certain sections during one visit and to continue the rest of the assessment at a future visit for certain patients with complex issues. So really, there's no single test. Just to summarize, there's no single test. There's that single process that should be observed.
Great. Thank you, Denise and Richard. Moving on to next question, I guess a comment rather, but sharing from their own experience. But as follow-up to questions, in our experience and research, exercise is the recommendation that is least often followed up on. We try to actually practice a home exercise program in the clinic to give clients a strategy for beginning exercises at home. So that's a great experiential experience. Thanks for sharing.
Yeah, and just to quickly shout out Rhonda Field, physiotherapist with the Fraser Health Fall Prevention Mobile Clinic, and she is one of our fall prevention champions in BC. I'm so thrilled to be able to work alongside her in public health, and she also did a Loop webinar that's recorded about the Fall Prevention Mobile Clinic. So please do check that out if you haven't. She's somebody that we are privileged to be able to learn from.
Yeah, no, just to follow up on what you just mentioned, Rhonda, your presentation is amazing, just by the way. Just to say, here in New Brunswick, there's a program called Live Well, Bien Vivre, who are mainly health coaches who are there to support New Brunswickers of all ages, actually, with motivation to continue with their efforts to be healthier. Now that involves, not just physical activity, but also smoking cessation, proper nutrition, and the other elements of wellness. But for our purpose is our effort to partner with that program in order to help with referrals for those older adults who have difficulty adhering to their exercise-based fall prevention program. So those are efforts that are going to be ongoing, but that's definitely one of the concerns that we've identified here in New Brunswick also. So interesting.
Great, and yes, thank you, Rhonda. I'd love to hear that. And yeah, the last thing in our Q&A is just a reference for effectiveness rather of hip protectors. And I saw that in the chat, there was some other literature links getting thrown into there. So if the person who asked about hip protectors earlier didn't already catch that, please feel free to check that out before the webinar ends. With that, we don't have any more questions in our Q&A, so I'll roll into closing remarks. Unless anyone has any objections, I am sure glad that we extended our webinar to be an additional 30 minutes. I think it really allowed space for these awesome discussions, and I want to say one last thank you to our presenters, Brian, Denise, and Richard. It really has been a pleasure planning these with you, and your presentations are so rich. And I think from the feedback that we received at the last one, and the feedback that we'll hopefully receive from this one, that it's much appreciated to our audiences. So as a reminder, please fill out the evaluation survey that will come up at the end of this webinar. Also, if you're not already a Loop member, you can see the Loop URL is in the bottom corner of the screen that I'm sharing right now. That is where the slides will reside, and that is the quickest place to find all of our old webinars, our archived webinars and recorded webinars. So keep that in mind. If you aren't already a member, you may want to sign up to get all the good stuff out of this webinar. But with that, I'll say have a wonderful rest of your day, and thank you again to our presenters.